Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today we will be discussing about a case where the patient is hypertensive and diabetic. The pupil is hard to dilate. The cataract is soft, but the anterior chamber is very shallow, which we'll see in due course in this surgery. So the point that I want to make today is how should we go about such cases. What I suggest is do what is best in your hands and not to get intimidated by what you see others doing. So in such hard to dilate cases and shallow anterior chamber, I am more comfortable doing an SICS over doing a phaco. I feel using pupil expansion devices further shallows the AC, and the soft cataracts are not that easy to manage. So I have opted for an SICS as I will be more comfortable doing it and it will benefit the patient as well. So by now a subtenons anesthesia has been given and now I am making a groove. This groove helps us stabilize the globe easily and maneuver it as per our need. Because under subtenons injection we get good anesthesia but not akinesia, so patient is able to move the eyeballs. A frown shaped incision has been made and now is the time to fashion the tunnel. So with the crescent blade we have found the adequate depth. So as you can see, the patient is moving the eyes, but this groove helps us stabilize the globe. And just by the sweeping motion, we are able to create the tunnel. As the chamber is shallow, I am planning not to enter the chamber from the main wound as of now. So now I am making a side port. And a bit of phenocane is injected, hoping the pupil will dilate a bit, but there was no response. Though there was no response, but what I have seen is that this phenocane prevents further constriction of the pupil. So even if this pupil stays till this size, we will be able to complete the case. Now you can see the moment I am inserting the cannula, I am hitting the iris. The chamber is that small and shallow. Now is the time to enter. The staining is not that good, but it should suffice. Now the main challenge is doing an adequate size rhexis. So we need to go behind the iris, underneath the iris, to create a sufficiently adequate around 5.5 to 6 mm of rhexis. Now you can see that while I am making the rhexis, this iris is getting lifted up, which is indicating that the rhexis is going well and of the size that I wish. Hydrate while hydrodissecting, we have to be careful not to over inject the fluid because this iris seems to be floppy, and if we increase the pressure behind the lens, then it might push the iris and we might face iris prolapse. So gentle amount of fluid should be injected. Now rotating the nucleus is brought into the anterior chamber. The pupil is so small that it was quite difficult bringing this nucleus out in the bag. Now is the time to bring the nucleus out by using an irrigating wire vectis. Now while cortical removal, we are not being able to see the edge of the rhexis, so care should be taken not to hold it. So take your time, there is no hurry. Once you are sure that you have caught the cortex, just pull it out. So slowly but steadily, I was able to remove the cortex, and now is the time to place the IOL. So we have chosen a multi-piece IOL for the patient. The leading haptic goes in the bag. This small pupil holds the lens and prevents it from coming out. And now the trailing haptic is gently dialed in. So now we have this lens in the bag, and now is the time to thoroughly wash the viscoelastic substance. So the take-home message is, do what is best in your hands. Don't get intimidated by what others are doing. You have to do what is best for your patient. And needless to say, this patient was very happy. The vision was 6/12 parts, and with correction it was 6/6. So the wound is closed and the case is concluded. Thank you so much.